Welcome everyone to today's webinar. I am Erin Deach with Becker's Hospital Review. We will begin today's webinar with a presentation and will have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Bill Gaynor is a healthcare IT and payments executive at MarkLogic. Dr. David Danhauer is System Vice President and CMIO at Owensboro Health. Marcy Schmate leads Strategic Development and Innovation at Scan Health Plan. And Dr. David DiLoretto is Senior Vice President at GE Healthcare Camden Group. Bill, I'll now turn the floor over to you.
Thank you. Welcome, everybody. Thank you for attending our webinar, bringing panelists together and industry thought leaders together about enterprise data strategy, powering modernization, innovation in healthcare. Wanted to first start real quick with a quote. I'm sure many of you have seen this movie, but if you haven't, I thought it was very poignant for today's healthcare environment. The quote says, "It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so." And the reason why I thought that was very applicable to today's healthcare environment is because a lot of the innovation and digital transformation initiatives are being thought of in terms of 30-year-old technology, and it's the things that we are comfortable with and think we know for sure that are trying to take us in the direction we want to go, and without understanding maybe the limitations or constraints those are putting on getting to where we want to go faster. So as a quick icebreaker here, I wanted to kind of throw out to the audience here, and you can use your question response button. But the question I have for you is, healthcare organizations are having some data challenges that are driving innovation and transformation. Real quickly, I want to take about 30 seconds and see if anybody would like to take a guess on what the monetary figure is now per healthcare breach. And I've provided some information there below that healthcare breach is about $355 per record. And other industries, including financial services, are about $158 per record. So if anybody would like to take a stab at in their question section of responses, trying to put in a number figure, what they think per breach, what it's costing a healthcare organization today. Good. We've got a couple of responses here, and some of you are close. For those of you who like the Price is Right, you have to guess but don't go over. The figure is actually $4 million. So it's a significant area of opportunity and risk management for many healthcare organizations. One last one here, and then I'll just give you the third one. But what % lower satisfaction do you think healthcare organizations or healthcare service companies have today compared to other related industries, service industries? Also, you can use your question response button again. So this is the % lower satisfaction compared to other service or tangentially related industries. Good guesses there. More on the low side, per the St. Metrics industry study, it's about a 50% lower satisfaction when compared to other service industries. Just to give you a scale, healthcare in general is around the 10 or 15 Net Promoter Score rank. The highest in the industry is Kaiser, which is around the 35 point Net Promoter Score rank. Amazon, in comparison, is around the 77 point rank. So in the final message here, CMS published some of the final fee-for-service schedules, and I think many were surprised that at the % that was taken off of some of the high-dollar, high-utilization services like imaging. But a lot of the fee-for-service, those fee-for-service categories took about a 20% reduction coming into fiscal year 2017. So with all these pressures with security and compliance and, value or consumer satisfaction, and then, the impact that it's having on the traditional payment model, that leads us into why would you fuel your innovation and digital transformation projects, using the same old technology? Well, the cost of using the same old technology is about 80% of the time is wasted. So one of the new and most popular positions in healthcare is data scientists. Well, would it shock you to know they spend about 80% of their time normalizing and massaging data, not necessarily just developing the insights. The costs of aggregating things in traditional data warehouses with the extract, transform, and load process, or ETL, is about 60% of both the initial and ongoing costs. And then per Gartner, about $3.5 billion was spent in data integration last year. So it's significant all around the board, but business as usual is not gaining the results in enough time. So our message that we'd like you to hear from today from our panelists is that innovative programs and digital enterprise initiatives require modern and agile data technology. And MarkLogic is just that. We've been around for 14 years. We're on soon to be version 9 of our software. In the center of the screen there, you can see some of our notable healthcare clients or references. And we have a wide range of consulting, online support, community, and web-based training services available to the community. We've solved significant data integration, enterprise-level challenges at 3 of the top 10 payers, and more notably, in healthcare.gov, when it was struggling early on, MarkLogic played a significant role in the data aggregation, data layer of getting it live in a very short period of time near the end of the go-live process. So a lot of the things that have spilled over into what healthcare people are using modern and agile technologies for today in healthcare is, if IT folks are talking about some of the things on the left, so when they're looking for new and agile modern technology or software, they're solving the technology problems on the left, and then the business folks are looking for new and modern technology on the right. So it's everything from mergers and acquisitions to product and plan management. And the reason why they're looking for modern technology versus things that are 30 years old and very rigid is because of the middle. Flexible data model, unstructured and structured data, fast ingest and search, and enterprise reliability. Dr. Danauer?
Thank you very much, Bill. I appreciate this time and being able to present today and be a part of this initiative as we push forward and always looking for the better way. As part of an introduction, next slide, I'm a CMIO here at Owensboro Health in Western Kentucky, and we service most of Western Kentucky with our hospital and our system, as you can see here. Our driving force, our main initiative that we do here at Owensboro Health is patient quality and safety. It's our guiding light. It's the driver for all of our initiatives as we go forward. And one of the major problems, next slide, that we saw is physician documentation and the work associated with that as we went live with an enterprise EMR, that the change that physicians were going to have to go through in managing those notes from paper to now an electronic version of that, this was a massive change for physicians in their day-to-day operations that they have to deal with. And so what we came up with was how do we manage this problem for them? How do we streamline that ability for those physicians to get the data into a record with the simplest and ease and use the technology that we have available and still get the right information into in our EMR that possibly could be as discrete as possible. So these were the issues that we had. The patient story was actually lost. All we got were templated notes with no real information about what that individual patient was dealing with that was unique from other patients. We saw lots of templating, notebook, copy paste. Notes were 10, 12 pages long now when they used to be half a page long. Lots of data in it, didn't mean a thing to those who were trying to use that as part of the care team. Bottom line, when you get down to coding and getting that that bill out the door, we couldn't even get coding moving because our notations were so poor. Next slide. So in quest for that information, we wanted to get some type of new technology to streamline that process, and you can see there it had to be functional, easy to use, maintain current workflows. Don't take physicians out of their normal workflow. It needs to be integrated with all the other systems that we're using at that time. The outcomes have to be improved notes, so we can get that communication across the care team as best we can, and hopefully being able to then transform that unstructured voice transcription file, whatever it is, to more discrete data to be able to use it and not force our physicians to be data entry clerks as they've been so complaining of over the years. We also, at the very end of the whole deal, did we win? Did we get the results we wanted? We wanted metrics-driven return on investment to know where we were going, and show worth that we had. Next slide. So here we are. We put the typical process in place for bringing around any new project, bringing the right people. We had the stakeholders. Getting physician engagement was critical. And I will tell you, in my process of doing this, I got all the naysayers. I brought in the worst of the worst to try and make this as positive as I could. And I knew if I could win them over, we were going to have a very successful go-live and implementation. We did a head-to-head business and technology evaluations with the different vendors, formal ranking, et cetera. And we went to the vendor, and then we developed the project, including outcome metrics. Next slide. And these are the outcomes that we did, and we're certainly focusing on physician satisfaction. The ease of use was critical. We now were able to give them 5 different ways to document in our medical record to meet, the older physicians, the younger physicians, all the different ways they wanted to get notes into the chart. We wanted to give them as many options as they could to streamline and get that patient story across. We did a recent survey, and over 70% were favorable with the use of the system, and 41% of the physicians we were able to survey said that the results were average or certainly exceeding expectations of what that note should be like. Very, very surprising that physicians were reading others' notes. As you can see there, the quality of the notes improved as well. 83% were favorable. 37% were in the highest 2 rankings, above average or certainly exceeding expectations. So now we have physicians reviewing other physicians' notes, and that quality went through the roof. We were quite excited with that. One thing I skipped there was that we don't lose voice files now. That was a big complaint in the prior voice recognition technology that we were using. Now we have a cloud-based solution with no lost voice files, and it's certainly mobile and easy for the physicians to use. An additional thing we found was our turnaround times for all of our HIM requirements were markedly improved. Our turnaround times went through the roof. So physician satisfaction went up because of it. They didn't have to wait forever to get transcriptions back. Next slide. So now, what was our ability to get unstructured data into discrete data? 53% response. So when we present recommendations for improving their documentation at the time they're documenting, over 53% of our providers are actually responding to those cues using CAPD, computerized assisted physician documentation. Most of our alerts that we've turned on to this date have been ICD-10 documentation cues, and therefore our queries out to physicians have significantly decreased as well for ICD-10. Coding, all the anticipated backlog that we saw with the predictions with ICD-10, we have been current now with coding over the last 6 months. We certainly are now looking at other quality issues in patient safety. 2 specific use cases are looking in the record, reading in contextual data associated with abdominal aortic aneurysms and incidental lung nodules. Both of those are high-risk critical issues that need to be addressed prior and as early as we possibly can in the care of that patient, we're now able to actually read contextually those notes and get those patients that have been found with incidental findings of these out to the corrective providers. We are now using care managers to motivate those patients to get to the right care now before that time is critical for those patients. Next slide. Thank you.
So Dr. Danauer, before we go to Marcy, I just want to go back up to your results slide here. A couple of quick questions for you. Dr. Danauer, you were talking about how to take the unstructured data or turn it into discrete data. Can you also talk about how I think you shared with me how you're making it more actionable, so it was more concurrent with the experience. And, if you have any of the patient perspectives, that would be fine. If not, how did it impact the experience, and what are you doing to make it actionable so you catch more at the point of service?
Right. At point of service, if they're using our electronic record as they're putting it in, they now get cues live in front of them that says if they dictated or wrote, typed, put a voice file in that says CHF, they're getting cues right in front of them to say, is that right-sided, left-sided, acute, chronic? They're getting those cues to say, please give us more discrete, more detailed information that would help meet those ICD-10 criteria, but also now get us to the point of saying this acuity of the patient, the severity of that patient's admission goes up or down depending on the documentation you actually put in the record. The beauty of it is as that note progresses, if they don't address it in the beginning of the note, but they address it in the end of the note, the alert actually goes away without ever having to be interrupted. The alerts are non-interruptive, but suggestive only. And so now we have completion of these notes with much better information and in a real-time environment because of that ability to read the contextual note.
That's great. Thank you for sharing that. In terms of kind of like a team-based environment was something that was also, was that a direct benefit or unintended benefit of
which one? I'm
sharing
sorry.
Notes? Team-based, sorry. Having the notes be able to be shared and more actively read in terms of what impact did the team environment have on quality that you mentioned?
Absolutely. Absolutely. So first of all, physicians became satisfied with other physicians' notes. When we first started reviewing this, all my physicians were pointing fingers at each other saying, your notes are terrible. They wouldn't look at themselves and say, my note is terrible. And so once we were able to get these techniques to them, these abilities to use these notes and write them notes in a more succinct manner, everyone's notes started to improve, and now the team is actually willing to read each other's notes. They don't have to worry that they're going to get a 14-page progress note on every single patient and not read those notes. The notes are succinct. They're pulling the right information in. They're getting the patient story. Now they're getting the thought process of that provider on plan of care, next steps, new orders. All of the information needed for that daily care is available to the entire care team in a succinct manner.
Perfect. One final question for you. I'm sure it's top of everybody's mind who's ever tried to do something contrary or new. I know you said you brought in the naysayers, you brought in the worst of the worst. Was there any specific tactics or successes that you used to engage and win over those naysayers?
Right. So what we did was make sure they were engaged in the evaluation process. We wanted them to make that choice as to what vendor, what functionality, what scope we needed to have, so that at the end of the day, when they're helping us make that decision, they own that decision, not IT, not the administration, et cetera. We wanted the providers who were directly using the product to make that decision. And the ultimate goal was that that's what they did. They made that decision. And our worst of the worst naysayer, 2 months after our go live, actually presented this at the board, live presentation in front of them, and he had 100% accuracy in the note that he transcribed in front of them on a patient that he was showing them how the functionality actually worked. I went and took the worst naysayer to being my best advocate for the system.
That isn't a success criteria. I don't know what is, but congratulations on your success, and stand by for the panel discussion to follow.
Absolutely. Thank you.
Now I'll turn it over to Marcy Schmate.
Great. Well, good afternoon, everybody. I'm Marcy Schmate, and I'm with SCAN Health Plan. I want to tell you a little bit about our plan and what it is we're doing and innovating for the future around healthcare IT. So our mission is pretty simple here at SCAN. We are in the business of keeping seniors healthy and independent, and it's been our mission since 1977. We started with a group of senior activists here in Long Beach, California, determined to improve the access to care and services that seniors so desperately needed. Our activists brought together experts in medicine, gerontology, psychology, and social services, and we formed the Senior Care Action Network, a non-for-profit health plan for Medicare. And we're still a non-for-profit health plan today, but we're really dedicated not only to serving our current 180,000 members, but we're also serving the community at large. However, as we look towards 2025, we know that we need to innovate, and we are doing so by creating some new innovations around augmenting senior life experiences. And we're doing so because we've identified three major pain points that we're trying to solve for through innovation. The first is being prepared. Seniors and their families are totally unprepared for what to expect when they age. And as a matter of fact, people typically will live at the edge of decline and have an incident creating a major family catastrophe or crisis. So being unprepared is a huge pain point. The second pain point that we're finding is isolation. As seniors age, especially if their family is not with them, they will retreat. So we are really focusing a lot of our innovation around perpetual purpose, making sure that people have the opportunity to find new work, volunteering, or are engaged in social groups. And the last pain point that we're working on through our innovation is remaining independent. So learning how to remain independent doesn't really exist today. And so one of the things that I'll share with you is how we're actually creating a new independent rise path. So we're taking 40 years of our experience, and we're creating a rise path around digital knowledge and a systematic approach of teaching people independence. Our program is 100% human-centered, and it's designed to learn about each person's individual preferences around independent living. So before I share that with you, I wanted to just share with you what our current health plan environment looks like. Next slide. So this slide probably looks familiar to you. For those of you that are payers or providers, the technology and systems that we are using today are centered around us. And our center of gravity is really our business and our business model, and it's not centered around our seniors. So as I look at this slide, it appears that the consumer, or the senior in this case, has to physically break through a barrier to get to the health plan and the providers that they access. Today we have an excellent customer service team that helps bridge, that front-end consumer experience to our back office, but those internal processes are siloed, and it creates a very complicated service model for us, ultimately not providing the best experience for our members. And even when our providers work with us, they too have to break through a wall to access information and insights around their administrative interactions, payments, and clinical support functions. So we need to do a better job of pulling all this together, and I'm happy that MarkLogic and Becker's are hosting this call today, because the solutions are out there. We just need to embrace them. Next slide, please. So as I shared, SCAN is a well-established Medicare Advantage health plan, and we have an amazing reputation with our seniors and the communities at large, including our providers. Our vision is to go from being a Medicare Advantage plan to becoming a senior-focused experience company. This means that not only will we provide insurance products, but we plan to provide products and services for all aspects of one's life from the age of 50 to 100 years of age. Next slide, or next. Yep. So these services may include a twist on mobility and transportation, connecting people with in-home tech, offering home care services, and much, much more. And we envision consumers engaging and using these programs as they deem relevant to themselves. So capturing these preferences and really understanding their needs and providing them service at every level requires a new delivery model. So it's our vision that we go from this archaic, system that we have today to a very personalized transformation. Next slide. So the technology that we have decided to use in our human-centered project is graph technology. Each of us on this call today engages with graph technology. The best-known consumer-centric companies use graph technology are Facebook, Walmart, and LinkedIn. Each of these companies uses the graph differently, but the commonality is how the graph is actually centered around the consumer. With Facebook, for example, they've created the world's largest social graph. Facebook knows, who your connections are, where you go, what you like, what you don't like, and they recommend content and social offers based on that social graph. For Walmart, their graph is centered around loyalty. They know what you buy, what deals you're interested in, how to incent you in the store or online. And with LinkedIn, it's an economic graph. So they're really experts in the data analytics and algorithms to connect workers to the broader business ecosystem. Each of these graph technologies puts the user at the center of the experience. The graph then learns and predicts the needs of the user. It also manages all of the relationships between and across the ecosystem such that the enterprise has the needed insight to drive customer intimacy and ultimately wallet share. And for those businesses that are not consumer-centric, they too are using graph technology as a means of creating relational experiences. So for example, Crunchbase is a business graph, the BBC has a storyline graph, and Google uses a knowledge graph. Next slide, please. So I tell you this because graph technology is not understood, but we experience it in our daily lives. And as we're building our innovations for the future, we're actually doing so using graph technology. So we have 40 years of our intellectual capital around how to live independently. And we know that there are 5 stages of independence. People need to learn how to prepare, engage, simplify, adapt, and balance. And within each of these stages, we're also learning or have learned that people are independent, interdependent, or dependent. And within each of these stages, there are triggers in someone's life that causes a specific need. So our goal is to help seniors and their caregivers learn self-efficacy around the stages of independent living. So our journey really begins by asking people what it is they really need. So seniors, so let me give you an example. An adult child may say that he or she wants to focus on remaining diligent at work, but he or she needs to make sure that mom is able to get to her doctor's appointment. And using our app, mom may say that her goal is not to burden her son, but that she needs an assisted ride to the doctor's appointment. The interaction tells us that there is an interdependent relationship between mom and her son. It also tells us that mom is in the simplify stage and she is slowing down and needs tailored services to achieve her goal of not only getting a ride, but getting assistance into the doctor's office. The graph then provides relative content and information around how to achieve this goal. The user can then learn or take action to achieve the goal. So let me show you how it works. Next slide. All right. As families use our app to express the new needs, and as we monitor the senior's experience, we update their progressive profile. With permissions, this independent living record can be shared with trusted advisors and with the primary care physician. With a profile that will span the stages of aging and with machine learning, will prove the impact of social factors within seniors' lives. Next. As we capture the family's new needs, we will use a graph to link those needs to relevant content. Based on their preferences, their personal stream may include a family story, educational content, or even evidence-based research. With this graph-driven capability, we can educate, and inspire on demand with essential information related to their need. Next. Each piece of content we deliver will be interactive. So after reading about the alternative solutions, a family can select the type of service they want and articulate their specific service needs. An algorithm will use this data, check their profile for location or other preferences, and then search the graph for best fit services in their area. Next. And after the service is initiated, a digital assistant will launch a series of conversations with the senior to ask about the service and ways to improve the senior's experience. Over time, the assistant will trigger additional conversations about new interests and needs. Everything the assistant learns will be shared with family and service providers. Next slide. So as we launch the consumer application for seniors and caregivers, this application resides within a broader platform that connects to the user's ecosystem. For example, our platform can serve employers, health systems, and post-acute care organizations. The value proposition is such that when seniors and their adult children learn how to remain healthy and independent, it helps everybody achieve better outcomes. Just some examples here. Nationally, employers will experience a $33 billion productivity loss when their workers are caregiving while at work. Health systems and providers need insight on independent living status and solutions so that a care plan can be adhered to. And post-acute care providers need help with transitioning of care into an environment where independent living scenarios are understood and solutions are in place. So to summarize, our independent living graph will determine preferences, understand somebody's specific needs. It will help educate and inform around the stages of how to rise to independence, and it will make recommendations and fulfill services at that very specific need level. At the end of the day, the graph will help teach self-efficacy around rising to independent living. And when we're at scale, SCAN will have created the very first independent living graph, the first of its kind in our industry. Bill?
Thank you, Marcy. Appreciate it. Marcy, you had mentioned, do you have any perspective of how long this has been going on at SCAN, and tell us a little bit about the process to get to this kind of more modern graph style, what things were considered, and kind of walk us through when you try to fit the right graph technology to the right business situation.
Sure. So our innovation team is relatively new. We're only about 6 months old. I was hired to come lead innovation here at SCAN, and the person who has been on point in getting us to this level has a human-centered research and design background. So this is all relatively new. And one of the reasons why we're able to kind of, do this is because our innovation group has been set up as a NewCo, and so it's very much not part of the health plan, but it's helping position the health plan for that senior experience 2025 goal. And so we're trying to, innovate for the future, but then walk it backwards. So it's very, very new.
So knowing what knowing that you're a long-standing technology veteran and entrepreneur, what is the biggest barrier in your perspective to having healthcare consumer experience be like it is in other walks of life?
I think it's just sheer will. I've done 3 startups, and I've been in healthcare for nearly 30 years, and I think if all of us had agreement that that having interoperability and shared information while delivering value to our customers was all a global goal, we would go further faster. So I think if we could figure out how to get over that barrier and really help serve the end consumer, just like the banks all communicate with each other and how retailers communicate with each other, I think that's really something that we need to do.
Okay, thank you very much. Please stand by for the open panel session. Dr. DiLoretto, you have the floor.
Yeah, hi, Bill. What I've enjoyed about the webinar today is, you set up nicely the challenges for the healthcare industry, that we're delivering services that are not consumer-centric, that we have compliance and security issues, and that the value that we're creating isn't what people who pay for it want. What was encouraging, that's a depressing story, and we hear that story pretty frequently. What I really enjoyed, though, is that the promise of digital transformation in the healthcare industry is now being realized at places like Owensboro Health and Scan Health Plan. And what was shared is unfortunately more unique than all of us would want, and I think that it's important that we think through how these transformations can happen more effectively. One of the things that you pointed out early on is that we're trying to approach 21st century opportunities and challenges with 20th century back-end technology. And so many of us have, as we move towards population health, have been using systems that work very well in a transactional world. As was pointed out, our EMR systems are largely oriented around transactions. They're not necessarily designed around provider workflow. On the flip side, the systems are not designed around what consumers need and want. And both the healthcare insurance and the healthcare provider industry share this challenge now of population health. They're using systems, again, that were designed around transactions and trying to adapt them for problems that are really more epidemiological in nature. The queries in population health now require very significant scalable opportunities, as well as the complexity of healthcare data, which changes more rapidly and in different ways than, let's say, in financial services, where relational databases and data warehouses built on relational databases can work effectively for longer periods of time. And so, to your point, the technology sphere now allows health systems to begin to think, and health plan providers to begin to think differently about the future, particularly with respect to back-end systems. Designing them, obviously, around what consumers need and providers need is going to be the challenge. What is also interesting, I think, is that these two industry verticals, the health plan side and the health provider side, now have opportunities to work together in ways in the transactional world that they didn't. There's value in sharing claims data, integrating it with clinical data in ways that now present new business opportunities for both industry verticals to address what Marcy just pointed out, that other industries that have transformed digitally created new value chains and new types of value chains where data was shared in ways that it historically didn't need to be shared. So it's really the promise of digital transformation in healthcare. And in addition to new technology and new ways of looking, particularly back-end technologies, it'll probably require us to think a little bit differently about how we organize ourselves at governance levels. Clearly more need for executives and directors with experience in industry transformation from a digital standpoint at management levels, information technology no longer being a support service for our companies, but becoming a strategic lever that we need to begin to think about differently. And also the need to give providers and frontline staff the opportunity to innovate. This is another promising area. We're seeing incredible innovation in care models on the front lines, folks very quickly designing around patients, but not supported necessarily with information to know how much value they're creating and entering into contracting relationships, because particularly in the U.S. of healthcare transformation at the payer level, that they need more support to understand, are they creating value? Where's the value being created? So these are promising stories, though, and congratulations to folks at Owensboro Health and at Scan Health Plan for the work that they've done.
Dr. DiLoretto, up on the screen now is, you could explain a little bit about your role at the Healthcare Executive Group and what this top 10 is And anything in here that particularly catches your eye based on the audience and the topics we've discussed today?
Yeah, the Healthcare Executive Group is an association of executives from both the health plan industry and the health provider industry who've been meeting for nearly 20 years. And in more recent years, they've been focusing specifically on this issue of how health plans and healthcare providers begin to collaborate in new ways. Every year, they conduct an industry-wide poll of what executives are thinking about on top of mind in every year. And you can see that this year's results clearly value-based payments. Because of in the U.S. of healthcare transformation, both payers and providers are having to deal with a host of issues around care model innovation, increased consumerism, the need to support back-end and create back-end systems that allow them to enter into value-based payment arrangements in ways that their old transactional systems never had to contemplate. The notion of total consumer health as providers and payers now share risk in new ways, thinking about community-based resources and their impact on individual members and population-wide health status becomes important. And of course, folks are spending lots and lots of time in the data analytics space and having to relook at how they're governing data, how data is getting created in the organization, how it's getting distributed, and how it's getting protected within the organization. So number 4 being cybersecurity right behind it. And then you see a number of the legacy issues that we've all struggled with years around the cost of care, access to care, and so this year, really the data analytics and supporting infrastructure, particularly around payment reform, really rose to the top, and it's been rising in recent years.
One last question before we move to the open panel discussion and some of the questions that we've received. From your perspective, Dr. DiLoretto, you made a very poignant comment, which was, we're solving 21st century problems with 20th century technology. Certainly, in the realm of population health, the holy grail is, how do you affect consumer or patient or member behavioral change? How do you feel about the pattern or rut we are in with using 20th century technology to solve 21st century problems, and how do we get out of that rut?
Yeah, that's
business and organizational side.
Yeah, this is another one of the areas where the two key industry verticals, the health plan as well as the provider side, actually share a common interest. Ultimately, particularly in the United States, the burden of chronic disease, asthma, diabetes, hypertension, chronic obstructive pulmonary disease is very, very significant. At the plan and provider level, enabling individuals to be engaged and activated in their own care becomes more and more of an opportunity. And it's another encouraging area, because we particularly see in the consumer IT space a lot of innovation actually being introduced that should help with the care, enabling folks to care for chronic disease more effectively. And so the innovation in this space is very encouraging. I'm working with a health plan client in one part of the country who's now in the Medicaid managed care space and provides 2 weeks of fresh food to individuals with diabetes each month who are able to enroll in the plan. And so the opportunity to impact chronic disease will certainly be enabled by technology, and I think that's an encouraging sign, but also folks innovating on the care delivery side and looking at incentives and benefits that make sense will be something that we'll see more and more of.
Fantastic. Thank you very much for your comments and representing HCEG here today. Let's move on to the open panel discussion. Dr. Dan Auer, since you went first, did you hear anything else from any other panelists that you wanted to comment on and or highlight or disagree with?
Right. I think that what we continue to hear is that 20th century technology trying to push challenges and initiatives for the 21st century. There's categorically that cost and time and effort and rebuild is a massive infrastructure change that's going to have to change to power all 10 of those things that it's on that list there for them. That is huge for us to try and get to that point. We're still using so many legacy systems, and where do you put that dollar in these decreased reimbursements that we're seeing, and we're tighter and tighter in our budgets? Where are we going to put that dollar to get the most bang for our buck, to get that better technology?
So that's a good question. I think there's a little bit of a tail wagging the dog or the dog wagging the tail kind of syndrome, and this is for all the panelists. But is it an app, or is it the app working backwards to the data, or is the data working forwards to the app? I had a colleague once tell me the best app in the world, won't solve the data problems, and you can have all the sizzle you want and appeal you want on the front end, but having a bad data on the back end of the app is ultimately going to expose the app and have people abandon to it. So what are your perspectives on investing in the front end in terms of is it applications and user experience first, or is it getting your infrastructure and data model right?
So Bill, I'll answer that, and we're actually starting with the data and the data model first, because you can then back that into a great user experience. But if you don't have the right data and the right insights to drive the knowledge and how in our situation how the graph learns, then you still have a bad consumer experience.
I have to agree with that. And the first thing that any of my providers, physicians, come to me with is, do they trust the data? I can throw all kinds of technology at them, but if they aren't trusting the data that I'm giving them, it's all for naught. And I think the patients, when we finally get the right data in front of them, are going to do the same thing. They're just behind the curve where my providers are already engaged in the technology. The data is absolutely critical.
Yeah, and I would agree, Bill, and add that by improving the efficiency, scalability of the back-end systems and data model, it frees up resources for writing the apps, to creating what can be done for end users to make it more innovative. And so that's exactly the place to start.
Yep. Good question.
Okay, any other questions or comments from the panelists before we move on to some of the questions we've gotten from the audience? Okay, so Dr. Danauer, the first question is actually for you, and the question is, can you provide some more specifics or techniques with the physicians in the progress notes? The question specifically was, did you say it was integrating voice recognition to the progress notes in the EMR? I think they're looking for a little bit more linkage between where was the new technology inserted in the workflow and how does it render itself? Right.
So I think I mentioned that we had numerous different methodologies to do it. So we actually, from the traditional transcription standpoint, we were able to use voice recognition on the back end transcription to improve turnaround times for those documents that were fully transcribed dictated and transcribed by other staff. The second piece that we got was what we call partial note dictations, and so the providers were able to pull in any kind of discrete data they wanted it from the EMR into their records, such as the problem list, current medications, any allergies, those things are already documented. They don't need to document them again, they're already there, but they can pull those critical things into the note, but then start to to use voice recognition files anywhere within that note that they'd like to make it occur. Those WAV files are stored in the note, and then on the back end, voice recognition is used, and then transcription on the second piece of that. The WAV file is then transferred to a transcription file and brought right back into the note very, very quickly. Within our time frame is under 2 hours to get that managed. So now you've got a blended system of a templated note, but also the patient's story from the physician's own word of mouth. Lastly is a fully templated note that the point-click service, etc., or front-end front-end dictation, that you have true voice recognition, that the physician edits, manages, takes care of, signs, and is completed. So his note's live and active as he signs the note. Those are some of the technology we put in, but we gave the physician all those options. Using that technology allowed us to have all those options for them, and on top of it, then they can actually do it mobile, on a phone or whatever, or at home, wherever they want to do it. So that was that technology. I hope that answered the question.
Additional information, I believe it did. If not, we will certainly get it offline and can address it. The one other question that came in was around data governance. The question was, from their past experience, creating a data governance committee is different than, being able to actually have the tools and be able to enforce whatever the data governance committee comes up with. I will just give you this perspective from the MarkLogic point of view, and that is that, it all happens, at the point of ingest, and having a system that is, is multi-model and is actually taking things in at the point of ingest and indexing them and not stripping off any of the lineage or, transforming the data prior to it coming in. I think the data governance all starts with being able to have the raw data and have it be indexed, searchable, and having all of the original source information intact. By way of contrast, the ETL, or the extract, transform, and load process, does exactly the opposite of that. It strips off the lineage, it waters things down into a common model, and forces things in such a way that you can't audit or go all the way back to the original creating source system. So in a lot of ways, the ETL process and not being able to ingest data raw as is a contributing factor to data governance. I would say the other opposite side of that is a more modern technology, which is Hadoop. Hadoop is a modern file store, but it is not indexing and making data searchable upon entry or landing into the Hadoop data lake or other different technologies. So from our perspective, it needs to be an advanced modern tool set in the front that is maintaining the integrity of the source of where it came from, indexing it, making it searchable. Any of the other panelists have a comment about anything you guys are doing regarding data governance and what you might have as far as best practices or policies?
This is Dr. Danhauer. I tell you that the most challenging part of all that we've done is data governance. The technology was easy. That's the simple part, but trying to get others to understand the data governance. But once you have the data governance, as you just said, if your infrastructure can't manage what data governance is saying, it was all for naught. And very, very critical that the IT perspective and then the governance perspective are very much in sync and can be capable of managing that governance that's in place.
And I'll just add, Bill, that the importance of data governance will become evident. It becomes the forum where these discussions can take place, where priorities can be set, where resource allocations can be prioritized, and there simply wasn't the need for it in the past. Today, moving forward, it's a critical part of digital transformation.
Yeah, absolutely.
The final question for the panelists, and if you don't mind, we'll go in order of Dr. Danhauer, Marcy Schmate, and Dr. DiLoretto. I have a final question for each one of you. In terms of, if you were starting fresh today as a brand new organization without having the legacy baggage of proprietary systems and things like that, where would you start and why? And then the second question would be, then I'll ask a second question, but if you were an organization, where would you start and why? If you were building either a health plan or a provider from the ground up today.
Okay. Our discussion's on about data, and I've said it for years from a practice into what we're doing now. Data is king. Those who have the data, they are going to survive. If they don't have the data, you're not going to survive. You have to be able to build everything in your systems to manage the data that you need to have to make good business decisions for the future. And You've got to start there, and if you do that well, you can manage forward very, very easily.
Marcy?
Yeah, so I have the luxury of actually starting from scratch as SCAN has built new code to test the waters here. But we're really starting with our consumer in mind, and then building the interoperable ecosystem to support that consumer and every aspect that touches their lives. So we're from the gate kind of getting rid of our own notions around what it means to serve somebody in our space. And then it gets to the transaction level. So whether somebody's buying services and there's wallet share that's created, that's kind of the last step in the process. But you're really using the right technology to understand consumer preferences and needs at a very detailed attribute level, connecting them to the ecosystem and making sure that what we're building is not just for ourselves but for the entire community at large.
Yeah. And Bill, it would be probably to take a small group of committed clinicians and software developers and spend a few weeks with someone with type 1 diabetes, trying to understand what their life is like, what they're trying to accomplish, and designing a system around what we discover.
If we could go back and rebuild our healthcare system to that, wouldn't that be wonderful? All right.
It would be.
Yeah, that's the magic wand. So now I'm going to ask the final closing. This is the last question, tough question. We'll go in reverse order. Dr. Loretto, Marcy, and then Dr. Denauer. But so the reality is we've got a bunch of existing organizations. Some are coming together through merger and acquisition. The line between provider and payer is getting blurred. In terms of how we can take the biggest steps faster forward, if you're an existing organization today, saddled with a lot of legacy, sunk cost infrastructure, what is the best bet to apply modern technology? Where are the hairballs, the dirtiest, most challenging data that's holding back, modernization or transformation or new business models?
A couple of thoughts here, Bill. One would be the M&A process itself. And, historically in the industry, it's been around scale. I think that going forward, more M&A activity will be around capabilities and the ability to develop or bring in capabilities that are going to make an organization a better population health manager. And some of these may be some new interesting partnerships. I think if you're in the process, as many folks are, of having to integrate 12 or 14 hospitals or 3 health plans with legacy systems, you're going to need to be thinking about that through the due diligence process fairly actively and getting a roadmap that is fully informed and looking for those milestones, make sure that you're meeting them. We see a lot of folks creating clinically integrated networks, ACOs, who are on their second and third round of enterprise technology they're putting in for population health management, and they really need to reprioritize at the start around certain milestones before they spend more and more money in that space.
Thank you, Marcy. We've got about a minute left.
Yeah, I would just say our transformation is really around making the experience so relevant and personal to the end user that they want to engage in their health and well-being and their independent living. But they can only do that if we're connected to the resources in their communities, whether it's the medical delivery, whether it's the delivery system, housing, financial, anything that impacts, seniors' lives. We need to have an open platform that transcends all of our boundaries and is directed exactly to that end user.
Dr. Denauer, you can have the closing comments.
All right, I think that, as we go into these budgetary things I've mentioned prior, the cost of trying to manage all of these systems is going to be extremely difficult, and you just cannot throw the baby out with the bathwater. And in this case, finding that third-party vendor, third-party interest out there to help bring all that information together for us as we bring large systems together, that's about the only way you can do it. And then transform those internal systems as you have capabilities. So.
Great. Well, I wanted to thank you all for your participation today. Thank you for being thought leaders and helping drive the industry forward. And to the audience members, thank you for your spending your valuable time with us this afternoon.
That's great. Thank you.
Thank you.
Thank you.